All right, got it. All right. Bear with me 1 second, everyone. One second. There it is.
Do you want to do a few?
All right.
That's okay. Yeah. Do you pick?
Welcome, everybody, to our immunization economics seminar series. We've come to our last session of the season, of the semester. And today we have a great presentation by Katarina Haug, and who's a professor of health economics and deputy director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics at the School of Public Health at Imperial College, London. And she's joined with her colleague, Patrick Doohan, who's going to share the presentation duties with Katarina, I think, today. So you get 2 for 1, everyone. And the talk is about integrating economic and epidemiological objectives in the optimal response to pandemics and the role of analytical modeling using the dataless model that they've developed. And so if you've come to other of these presentations, you know, generally what we like to do is let the presenters go through their slides, and then we'll have some time for a discussion at the end. Usually we have about between 15 and 20 minutes for discussion at the end, and I'll moderate that discussion. And if you want to ask a question, we ask that you either type it in the chat at any time, or if you want to speak, you can raise your hand with the Zoom feature for raising your hand, and then we'll kind of call on you in the order the questions are received. All right. So without further ado, Katarina, I'll turn it over to you.
Excellent. Thank you so much, Steve. And it's a pleasure to be here at this fantastic seminar series. Yes, so today we're going to present work which we have really started at the beginning of the pandemic. With a team, with a fantastic team, of which one is here with me, socially distanced, Patrick Doohan in my office. But they're really to highlight the colleagues that have put an enormous amount of effort in developing this modeling. So that is David Hall, who is our leading epidemiologist, Patrick, who is here with me today. And then we have Rob Johnson, who has joined the team as well. Giovanni Fochini, who is an economist and helped us with the economic aspects. And then Matteo, also an economist, welfare economist, many others as well. And then not least, Peter Smith, who really developed the basic idea for this model and stuck with us all the way, although he's in semi-retirement, to help us with this. And I have to say, I think before I start, I have to say what a humbling experience it truly was, because, or still is, because never before have I worked in a truly multidisciplinary project, in the sense of that I, to this very day, do not quite understand the epidemiology behind it. And I know we always say that, right? We always say, oh, we don't, you know, but I mean, to really work with a team where you are one part of a big wheel, that has been for me, I think, a truly amazing experience, and continues to be so. And to just bring it all together, I think is just fabulous. So today, yes, so all the model that I will be, or that we will be presenting, is trying to trade off economic and epidemiological outcomes. And we called it Daedalus, and the reason being that Daedalus is the wise father that, of course, reminded Icarus not to fly too low to the sea, because the the dampness of the water would destroy the wings, but not too close to the sun either, because the heat of the sun would melt the wax that held the feathers together. So that, of course, for us was the perfect title for a model that tries to strike a balance in this agonizing trade-off between economic outcomes and epidemiological outcomes that policymakers around the world have faced during the pandemic and still do. Okay, so let me get in and yeah. So Daedalus is an integrated model of SARS-CoV-2 transmission. We have meanwhile, though, extended it to other pathogens, more of this later. It trades off economic gain, health impacts, and in-person schooling as well. It's the true core of the model was developed as an optimization model where we maximize GDP subject to epidemiological and health constraints. We have used it also in a non-optimization context. Again, more of this later. So the key questions that we are addressing in our work with policymakers are: how can we prevent lockdowns? What is the economic gain from opening the economy as the vaccination coverage increases and as we reduce other non-pharmaceutical interventions? What is the societal gains in terms of economic, health, and educational outcomes as we adopt different mitigation measures and vaccination strategies? What is the comparative impact of economic closures versus other non-pharmaceutical interventions looking at pandemic mitigation? We have also, so in answering these questions, we work with WHO and with countries, mainly low and middle income countries around the world, in helping them set up the model themselves, but also if capacity is lacking in countries still, we offer scenario projections for policymakers. We have also used it for the G20 higher level independent panel on pandemic preparedness to calculate the return on investment to pandemic preparedness. But we will be not, we tried to cram that into their presentation, but gave up and just thought, okay, we just focus on COVID. It was just seemed too much to do that as well. Okay, so I want to now give you a very brief and I would say high-level summary of how the model works, because it is actually quite complicated to understand this. But we have the equations of the model, both the economic and the epidemiological theoretical exposition of the model online. Also, the code can be downloaded on GitHub. It's in MATLAB. So people who want to delve a bit deeper than what I can talk about now, they can do that online. So how does Daedalus understand a country? So first, we have the economy, and the economy in Daedalus is structured according to economic sectors. So for example, agriculture, financial services, and so forth. The education sector is also considered an economic sector, but we treat it a bit differently to the other economic sectors, and I will explain later why. There is exchange between the economy and the community. In the community are individuals who are not working, children, and also people who are working from home. And there is an exchange between between the economy and the community by workers traveling back and forth between the community and the workplace. Also, people who are not working consume goods and services, and they will interact with the economy when they do so. Now, all of this, of course, leads to transmission, and that is considered in Daedalus, and it is also basically disaggregated according to the different components that you see on this picture here. So transmission is disaggregated by the economy, by the community, by the different sectors, and also by the different activities, and more of this later. Now, the economy contributes to gross domestic product by producing products for final consumption. That is the gross value added of a sector. For example, the gross value added of a sector 2 will contribute to gross domestic product. Now also, of course, there are complex interrelationships or interdependencies between sectors, because a sector will not only produce products for final consumption, but also produce essential inputs that are necessary for another sector to produce. So there are these complicated supply chains. So over the past 1.5 years, I think I learned more about macroeconomics than I could ever dream of as a health economist, but it has been quite interesting and quite a ride, actually, yes. Okay, so first we see that sectors vary in their size. There are just some work sectors employing more workers than other sectors. Now, what is obvious is then if they employ more workers, ceteris paribus, this sector will contribute more to transmission, because there are just more workers that are moving back and forth to the community, that are interacting with each other and with consumers. So, for example, a sector such as agriculture in many low and middle income countries will employ quite a few workers, whereas there are other sectors that have much fewer workers. So here the bizarre example of water transport, because that was for this particular country an important sector. All right, so that we do consider that these sectors vary in the sector size. So a policymaker may think, okay, so a good idea would be to close down this large sector, because if we send these as workers that are in this red block, if we send them home to not work anymore, then we will basically reduce the transmission that is arising from that. So Daedalus will, in the optimization setup, favor sectors for closures that have more workers. Ceteris paribus, everything else equal. Now, it's not so simple, of course, because sectors not only differ with respect to their size, but also with respect to the context they have. So there are some sectors, for example, hotel and restaurant, which have more contacts among each other on every day. So the average worker has more contacts than a sector, than, for example, financial services, which may employ the same number of workers. However, they just don't get into contact so much with each other. So we consider that in Daedalus with sector-specific contact rates. So again, Daedalus will favor then to close down the contact-rich sector and will say, okay, you guys go home. We have less transmission, but of course, we also have less GVA contribution from this sector, because we assume that when they work from home, they cannot contribute to the GVA of their sector. So in the impact projections and in the optimization, Daedalus will favor for closures those sectors that employ many workers, that are contact rich, and that contribute little to GVA. These three things Daedalus will consider in the optimization. How do we do then the impact projections? We consider how the transmission interacts, or the transmission contribution of the different sectors, the essential inputs, and then the contribution to GVA. We will say, okay, we have less GDP and less virus, and that we will consider in our impact projections then. So in summary, so this was, apologies for this slide, toy exposition, but we want to come to the applications as well, and that's why we keep it really simple here. But if you want to, as I said, read the equations and the theoretical background, then you can do that by following this link that I have here. Now, in summary, the population is stratified by age. We have these 4 age groups, so workers, retired, and then school children and younger children. And then we have economic sectors as they are in the input-output table that the economy has. So some economies have input-output tables which are quite detailed, which comprise of 64 sectors. Other economies we work with, they are not as stratified. They have maybe 35 sectors or so. Contact rates vary by age group and by economic sector. We have included now a vaccine component, but to reduce the overall complexity, we just have one vaccine, and we average the efficacy and the waning and so properties of the vaccine in order to keep a tab on how complicated that model becomes. So formally, it's an SEIR compartmental model with 39 groups if we have a 35 sector economy, but more groups if we have more. Disease transmission is controlled through the closure of economic sectors, which reduces health costs, so deaths, but incurs economic costs, GDP loss, and educational losses. So we project the short-term health and economic costs of the pandemic. So here's the epidemiological model with the vaccine compartment reflecting the compartments for those who are not vaccinated. We distinguish, we have an exposed compartment, and also distinguish between asymptomatic, mild, and severe infection. Those with symptomatic infection, only a proportion of them will go into hospital, and then again a proportion of them will die, and hopefully the rest will recover. Now, our model needs epidemiological data quite a bit. Quite a few data is required: age structure, population data, hospital occupancy, and case fatality rates, also age structure ideally. If we want to look at vaccines, we need to know about vaccine deliveries, vaccine priority groups, and uptake. And then we have the contact rates, which unfortunately, a very poor information, which comes from a French survey, although from 2012. Unfortunately, there isn't much information on contacts by sector, surprisingly. Oh, Philip is commenting. Philip, maybe hang on to your questions. Then we have economic data. We need an input-output table for this model to work. We need also information on employment by sector, because we need to know how many people are in that sector. We need ideally a gross value added time series over the past pandemic, and working from home proportions in these countries, and also some additional information. So epidemiological data we often have quite detailed, often on a daily level, which is really quite helpful. The economic data, not. Now, if we project health outcomes and short-term GDP loss, we usually look at 4 alternative ways of formulating scenarios. The first is an optimization setup. So we maximize GDP subject to epidemiological and health service constraints. Now, the constraints that we set are that the effective reproductive number, or RT, is smaller than 1 at the end of the projection horizon. With this, we assure that as we project different pandemics under alternative scenarios, or rather the optimization works this out, that we will not leave a legacy of accelerating infections at the end of the projection horizon. Also, in the hospitalization, we specify that the hospital capacity is never breached. So this makes it a short-term deterministic optimal control model, where basically MATLAB and the Genius computer program works out what the optimal sector opening and closure is over the projection horizon. So basically the model spits it out. Now, some policymakers did not want this optimization, although, of course, we as economists think that this is the ideal approach. But of course, there are other things that need to be considered that Daedalus doesn't consider. So there are also sometimes strategy given by policymakers where they, for example, say, you can't shut down our manufacturing sector. We need agriculture open, or so forth. We also have, for pandemic mitigation, a strategy that mimics optimization, which is a reactive closure strategy, whereby we close down as hospital capacity is about to be breached in the projections. And then we often do counterfactual projections of an unmitigated pandemic, which leads to enormous and high epidemiological costs or public health costs in terms of deaths, but low GDP costs. And we also have, on the other hand, the full lockdown, which has very low deaths, but high economic costs. We now want to present 3 case studies. First, the GDP maximization in the United Kingdom, Then we want to present work we did with an LMIC that unfortunately we can't name in Asia. And then also more recent work on valuing education deaths in monetary terms that Rob Johnson, our colleague, has been working on with Indonesia. Now, first, before I give the word to Patrick to talk about the applications, I just want to explain how what we mean with an economic configuration. So here you see something that we call the lasagna plot. So the lasagna plot shows us over time, which is on the horizontal axis, here you see every month since the pandemic started in a country, how much each sector was open or rather closed between 0, meaning full closure, and 1, fully open. We hardly ever observe full closure because the economy, every sector needs to be open to a certain extent to produce essential goods and services. You then see on the vertical axis the different economic sectors. So here we are looking at a 35 sector economy. So where, for example, sector number 1 is agriculture, and then moving up, we get between 3 and 16 numbers. These is manufacturing, and then going on, we have retail and so forth. And the little colored blocks will indicate to you, this is an observed time series, how much each sector was closed over each month of the pandemic. So you can see, for example, that here sector 22, which I think is their tourism sector or accommodation, was closed actually quite a lot, particularly at the start of the pandemic in April 2020. However, as we were moving in the summer, over August, September, October, you can see that the whole economy was much more open. And then as the country went into a second wave, they closed down again more the sectors, as indicated by the more increased shading that goes towards red. So this is what we are looking at and what we are informing our scenario formulations on. However, in the optimization, the model will spit out these optimal configurations for us, considering the interdependencies between sectors, so how much each sector needs to be kept open. Okay, so now I will pass on to Patrick, who will take my seat in a socially distant way to talk about the United Kingdom.
So the first case study that we will be looking at will be winter 2020 in the United Kingdom. And the manner in which the dataless model is employed is in an optimization. So we are going to be looking at the optimal economic closures that will ensure that hospital occupancy is never breached, and also we're imposing the epidemiological constraint that the effective reproductive number must be less than or equal to 1 at the end of the optimization period to make sure that things don't go out of control immediately afterwards. So here we see the lasagna plot for our optimal set of economic closures. So our model was fit to the epidemic trajectory up until September of 2020, and then we optimize over a 6-month period up until February of 2020, or up until the start of March of 2021. Our optimal economic configurations show that if we are just maximizing GDP, that the only sector to be targeted in a lockdown is the education sector. Since the contact rates in schools and in the education sector are much higher than other sectors. It is also worth pointing out that we have an economic constraint here, meaning that we can only close open sectors to ensure that the supply chains are respected, and this is implemented through the use of input-output tables. And we see that with this optimal economic configuration, our hospital capacity is never breached, and we are really just hugging this line here, the grey line, which is a hospital capacity of 18,000. So this particular example is showing the trade-off between the economic costs in terms of GDP and the health costs in terms of hospital occupancy. But really, there's also a three-way trade-off where we can introduce the value of education to this, and we'll talk about this a bit in more detail a bit later. But to have a preliminary exploration of the education trade-off as well, we now impose an additional constraint which says that the education sector must remain open at 80%, so that we must have schools open, most schools open. And how does that affect our optimal solution? So here is the lasagna plot for our optimal solution, in which the education sector, which I think is number 55, must be kept open at 80% or above. And we see that this constraint really introduces many more economic closures. We see in particular that the hospitality sector, which is number 36, must be closed. So we now have to shut down our pubs and restaurants. We see that we're also closing down other sectors such as public services, which would include hairdressers and membership organizations and many other sectors in order to keep our schools open. Consequently, we are also, this optimal solution will have a lower GDP than the previous optimal solution, in which we are just maximizing GDP on its own. So here we're illustrating the three-way trade-off between health costs, economic costs, and educational costs. The second case study we'll be looking at is COVID-19 in a lower middle income country in Asia. So we had again fitted our model to hospitalization and death data, and we wanted to do projections of different stringency economic closures and what the health costs and economic costs would be in each case. So we're considering 3 to 6 month period for projections. And the economic closures that we are experimenting with are based on actual closures observed over the last year and a half. So the lasagna plot that Katharina showed a few slides back was the time series of economic closures in this country. And these are the economic configurations that we are basing our projections on. In each case, we are also varying the stringency of NPIs or non-pharmaceutical interventions. And for each scenario, we can calculate the GDP as a measure of the economic costs, and also our health outcomes, deaths, hospital occupancy, and infections as measures of our health costs. So this is the lasagna plot as shown previously. So we have on the x-axis, we have the months of the years of 2020 and 2021. And just briefly to explain again, we have the different economic sectors, and the color then indicates the degree to which each was closed. So the economic configurations that we are experimenting with are highlighted by the arrows. So our low stringency economic configuration is given by August of 2020. And our high stringency economic configuration is given by May of 2021, in which we see the colors are more darker, meaning that there are more economic closures since prevalence was much higher at that time. So here is a 3-month projection in which we have severe economic closures. So we see that the resulting GDP loss is of the order of $3.5 billion, but the number of deaths that occur over this same time period is of the order of 2,500. So this is basically acting as an upper bound in terms of GDP loss, but a lower bound in terms of death toll. And this is based on the previous economic configuration of May 2021. On the other hand, we can also forecast the outcomes of a much more open economy. This is based on the August 2020 economic configuration from our time series. And now we see that if we impose this level of economic closures over a 3-month period, we have a much lower GDP loss of only about $0.2 billion, but the death toll is now almost 10 times higher, with almost 26,000 deaths occurring over the 3-month period. So this economic configuration as an upper bound in terms of deaths, but now a lower bound in terms of GDP loss. So in addition to optimizations, as we saw in the UK case study, we can also use the dataless model just to project the health and economic outcomes of different economic configurations and different levels of NPI adherence. So in comparing these different strategies and the resulting number of deaths and the associated GDP loss, we can also compute ICERs, or incremental cost effectiveness ratios, of increasing the stringency of economic closures. And so the ICERs, which would be defined as incremental GDP loss per life saved, can then be directly compared to measures such as VSLs, or value of statistical lives. So for example, in moving from the most open economy to the next level of stringency, so increasing the stringency a bit, we see that the GDP loss incurred per life saved is of the order of $41,000. So significantly less than the value of statistical life in this same country. Similarly, in moving from mid-low stringency closures to mid-high stringency closures, we see that the incremental GDP loss per life saved is of the order of $200,000, which again can be compared to the value of a statistical life. And so this is just demonstrating how the model can be used to guide policymakers as to what may be the most appropriate mitigation strategy for the country in question. We can also look at the change in the effects of changing vaccine administration rate. So this is the vaccine component of our model. If we increase the administration rate, how many deaths do we avoid? And it's not shown here, but we can also explore how can we open up the economy faster and reduce the GDP loss by increasing the administration rate.
What time is it? Yeah, so maybe I just quickly, thanks Patrick, race through Indonesia. Indonesia, a country where schools have been closed since March 2020. Now, the thing with input-output tables from which we get our GDP calculations essentially from is that education is probably undervalued. So that means that in any modeling, but in the optimization modeling, they will be always disadvantaged. We will always want to close down, the model will always want to close down schools because the GVA contribution is low, at least the measured one, and the contact rates are so high. And there are quite a lot of individuals involved in providing and consuming education. So, Rob Johnson, our colleague, had thought about how can we, in a country that had so severe school closures, how can we put a fairer price on schools in the data loss model, or in the loss to education? So the assumptions we have that is remote teaching is about 1/3 as effective as in-classroom teaching. Now that happens in Indonesia as well, but of course with lower coverage of electronics, and so that is difficult. So we also had to make some assumptions on the attendance over the whole period and so forth. So our objective was then to value the societal loss in education and the lost life years in monetary terms. So we were applying existing estimates of the cost of schooling, lost schooling from the OECD for Indonesia, and also the statistical life year valuations for Indonesia, in order to put everything neatly in a monetary context, of course, with the caveats that we are all aware of attached to this. So the question then are, how much would we close the other sectors in order to open the schools without exceeding hospital capacity? And what is the optimal configuration that maximizes education, economic activity and minimizes illnesses and deaths. So here you can see basically how we are trading off economic activity in schools. So you can see that the maximum hospital capacity lies somewhere at 0.5 something. So that is the horizontal gray line. So we got to stay below that. Unless we want hospitals overflowing, which of course is something that every policymaker wants to avoid. And then on the horizontal axis is a level to which education is open. Now at the for most of the past year, education was close to the level of 0.1, so very closed. That, of course, allowed the economic sectors to be more open. Now, the question can be asked, is that optimal if we put that into a monetary context, valuing education fairly? So now the different colored lines indicate by how much we can open education compared to the counterfactual situation that we are in at the moment by increasing the stringency of the economic closure while still staying within the hospitalization capacity threshold. So we also have made projections for the local policymakers here until the year, until 22, spring 22. So here you can see the pink lines is hospital occupancy under 3 different scenarios. And the black lines are cumulative deaths under the same 3 different scenarios. The gray band is lower and upper bound of hospital capacity, so including and excluding spare capacity. So we can see that the baseline is the solid line. So if you look at the deaths, we can see that this is the current situation. Schools are open to only 0.1, so catastrophically closed, and the economy is near open. So we set that as a baseline as 1, and then we ask the question, if we were to open if we were to keep the schools like they are at the moment at 0.1, but we would close the economy double to what it is now, how would that reduce our deaths? So that you can see in the dashed line. So the cumulative deaths would go down, and also the hospital occupancy would go down and actually would go below, or would stay within our spare capacity. So that would be a good thing. But of course, that means that the schools are closed and we have these high costs associated with the closure of the schools. Now, if we were to say, okay, let's open the schools from level 0.1 to 0.4, because of the school being so contact rich, the school opening will lead to an increase in cumulative deaths and also hospital occupancy, as you can see with the dotted line. And also in order to keep that within reasonable levels, we would need to close the economy a lot. So we have also calculated that in monetary terms, but I cannot present that to you today. But this is forthcoming. We are writing that paper at the moment. So just to conclude now at this stage and allow some discussion as well, there is clearly an agonizing trade-off between deaths, GDP, and educational outcomes in all this. We have seen as presented by Patrick that with different stringencies of economic closures in the Asian LMIC, we are the policymaker has to trade off between 2,500 or 25,000 deaths and a GDP loss of 3.5 billion versus 0.2 billion in the different scenarios. I found it actually quite interesting when we presented this to the policymakers that they said 25,000 deaths over 3 months is totally unacceptable for us and would not be something that they wanted to engage with at all. We could see that in the UK application, if we actually optimize the whole thing and we compare this to a blanket lockdown, we have run the figures over 6 months. This would save us between 163 and 205 billion pounds. So if we optimize the closure versus just lock down everything that's non-essential, depending on where our hospital capacity threshold lies. Now, of course, policymakers have to consider many factors. And I can't even start to list all the limitations of this model. So it's hard to know which one to list first, actually. But I think the most salient one is that we have no voluntary behavior change in response to high disease prevalence. So arguably in an unmitigated pandemic, people will stop consuming things, will stop going to work. So that will have profound impacts on the economy and of course on infections then as well. We are not considering this feedback effect in our model. Then also our models are very sensitive to adherence to NPIs. Now we try to base this on kind of past observations in the way the model is fitted, but still what we assume about other NPIs, so face masks and social distancing and so forth, and limits to social gatherings, we found in sensitivity analysis, our model is sensitive to this. Now, we don't consider international trade, we don't consider migration and so forth. The list goes on. So we are continuing though, despite of that, to work on the model also with our partners in country who have and are making super valuable suggestions on where to improve the model, where increased complexity is worth it. It's hard to know. So we are looking at the moment at alternative vaccine rollout strategies, booster vaccinations, and then we have done some methodological improvements, but continue to do that. So assuming nonlinear production functions and many more. So we also have worked on the return on investment to pandemic preparedness. And there is a seminar that actually we have in the same setup, you and me, which is online on the Center for Global Development website, where you can see basically the model applied to pandemic preparedness. And there are the links at the moment to our publicly available reports, also where you will find a link to the GitHub MATLAB code. Thank you very much.
Thanks so much. That's really interesting stuff, Katerina and Patrick. I think we have I just want to invite people if they want to ask questions. If you want to ask questions live, you can raise your hand in the Zoom feature for raising your hand. I think it's under reactions, and I'll call on you. But to kick us off, we had a few questions in the chat already. I don't know if you can see those, Katerina, but David asked a question about how the sectors of the economy are defined empirically and whether there are geographic concentrations or distributions taken into account, and has another question about maximization and whether it yields a global maximum. And if there are multiple closed situations, can they be examined to understand different sector closures that yield qualitatively similar results?
Yes, so I can see the chat, so thanks for that, David. So maybe I start with the sector definition and I pass on to Patrick for the maximization. So first on the sector's definition, yes. So I mean, we have learned more about input-output tables than we ever wanted to know, but what we learned is that it is an enormous endeavor that is done by countries as part of the national accounts. In how far is that empirically based? Yes, I think they are empirically based, right? So it's an evaluation of how much each sector produces for final consumption, for exports, and there are some other nitty-gritty details, as you can imagine, related to this. And then also how much they contribute to another sector. This is all valued in monetary terms. Now, how exactly they are empirically doing that, that is, I think, a question for the expert that I can't answer, but it is empirically based and it's done by macroeconomists and keeps them, I'm sure, in bread and butter. Because this is such an endeavor, it's only done every 4 or so years, even for high-income countries, for low-income countries, even less. And that's why I guess they are notoriously outdated and do not reflect more recent changes in production processes, in technological innovations, and so forth. Now, are they disaggregated? Okay, some countries have attempted to do input-output tables, like I think there exists one for London, but you can imagine that's really difficult to say what is produced in London versus what is produced in the rest of the UK. So I don't know how reliable these attempts are. We didn't go into that details. So that means if we had some requests, oh, can you do, what happens if we have like these tiered lockdowns, whereby we lock down part of the country and the other part we don't. We can't do that with data loss. So our model is not suited. On the economic side, epidemiologically, it's possible to do that, but our colleagues here in the department, I think they're better suited and to do that epidemiologically. So we have stepped away from that. So maybe, Patrick, do you want to answer the optimization question?
Yes, sure. So it's very much possible that there could indeed be two different local maxima for the optimization. So what we input, just to recall, for our optimization problem is that we must specify a level of hospital capacity and we must stay below this. And we're also inputting our input-output tables, and the economic configuration must satisfy a linear inequality based on the input-output tables. And the optimization and the maximum that we hope exists, it doesn't always exist. It varies quite a lot according to the hospital capacity. So if the hospital capacity that we set is very, very low, there may not be an optimal economic configuration that satisfies the economic constraint that supply chains must be respected. But as we increase hospital capacity, as we allow more people to get infected, then as strict economic closures are not required. And so it is more likely that we will find an optimal solution. But yes, it is indeed possible that there could be two maxima with possibly different GDP values, and so we have to be careful that we try different initial conditions, etc., in order to compute the true global maximum.
Thank you. I think we have a question from Kevin Willison, who's asking about the loss of education and whether you factor in subgroups such as international students, which generate significant revenues for the education sector.
Yeah, that is an interesting question. I mean, I think it's a shame that Rob is not here to answer this question, who has worked on this more. Yes, so of course, when we look at the GVA contribution of the education sector, then that would be calculated in terms of the fees, right, that the students pay. Now, the price that students pay for education in that particular year is probably a very poor estimate or an underestimate, let's say, of the gains that are generated by education over the lifetime of an individual. Because that is the case, we have attempted to use this prior study by the OECD that have attempted to value this in terms of earnings, in terms of other valuable outcomes that are arising from education over the lifetime of an individual. And they have done that so that we can apply it to Indonesia, because they have done it, I think, by GDP of the country achieved. So how much of that, so they have calculated these educational gains in relation to the GDP of a country, which allowed us then to triangulate that for Indonesia. Now, obviously, this estimate then is much higher than the contribution according to the input-output table of education. Now, we haven't done that though for different student subgroups. But I guess it's an interesting question to contribute that. I mean, we have just really come from the angle of saying, well, it's easy, of course, to close down the schools, and that will make a big impact on the pandemic trajectory. And also, it doesn't lead to a high short-term cost, but of course, the long-term costs are enormous. So that was really our concern with education.
Sabit in Ethiopia, EPHI Ethiopia asks, were public health intervention costs included, like vaccine costs or disease treatment costs?
No, we don't take these costs actually into account. So our model really is best suited to model the costs of lockdowns and the gains of avoiding lockdowns. Now we have occasionally included other costs. So for example, people have criticized and said, yeah, why you need to also calculate the loss to the economy of people who are sick or who die. We have done that, and then surprisingly, we have realized that unless you have an insane quarantining system where basically half the country is sitting in quarantine and not working, unless you have that, the age stratification of severe disease and death is so strong with COVID, meaning it hits the elderly, that even if you have an unmitigated pandemic, the people who are actually out of work aren't actually that high, so that it doesn't factor, if you compare that with the loss to GDP, which is about 25% per month when you lock down an economy, which is enormous, is so low that we have thought that we are probably not at the moment having that as a priority to add that. Sorry, that was a very long explanation on these other costs. Thanks.
So Pauline asks if the software for modeling is available for use and free, or should there be should it be between collaborating institutions? I think you said that there's a GitHub, but I don't know, how do you?
So if you see the link on that website, on the slide that is still up, if you go to that link, and then you go to the appendix, and then in the appendix is a GitHub link. Huh? Yeah. So that's how you work your way to this.
And David asks, which is a good one. I was curious about as well. Have there been attempts to validate the models, to compare the model's prediction to empirically observed past outcomes? I suppose as time has gone on in the epidemic, there's more data available, and has that led you to do any calibration or validation or updating of parameters as time has gone on?
Yeah, I think there are three parts to that question. I think the first is, and I'll let Patrick talk about the calibration. I think what's important for us is that we calibrate that model to every pandemic that we model in every country. So that is really a task for the epidemiologists. We are not really used to doing that as health economists, right? I mean, when do we calibrate a model really to the past? So the epidemiologists on the team, they will calibrate that, and they will use hospitalization or deaths data under the knowledge that there's imperfect reporting. So usually we do not take case numbers because that is very influenced by testing data. But I will let Patrick answer that in a minute. But I think there's also another important aspect, which is that these are projections. So these are projections that are done at the time. They are asking what if questions, right? Again, as health economists, we are not very often doing projections. We are not using a model to project forward. We are usually using observational data, and then establish some kind of quasi-experiment to infer causality between variables. But so this is not at all what we are doing here. We are projecting into the future. Now, so it's very difficult to actually say what was the real policy course in the end taken, right? What was the real policy course that was taken, and how does that triangulate with the projections we have done at the time? And the problem why this is so difficult is that a policy path is never a clear scenario A or scenario B. It will lie between extreme scenarios that we project to policymakers. But maybe you can talk more about the calibration and how we do that, Patrick.
Yes, sure. So just to remind people of the Lasagna plot, so we have a time series of economic closures, and different sectors will have different levels of closures. And so this will affect the contact rates and the amount of daily contacts for the workers in each of these sectors. And so what we want to translate this onto is the observed epidemic trajectory as measured, as Katharina said, usually by hospital occupancy or deaths. And what's missing, or what's the go-to between, is basically a parameter that captures the change in people's behavior. So we might have early on in the pandemic, in the first lockdown back in early 2020, there was quite a drastic change in behavior because there was a lot of uncertainty about COVID. And so people's behavior changed quite dramatically, and we see that the corresponding parameter was quite low. But then as at different times during the pandemic, the change in behavior may not have been quite as extreme, say in periods of lower prevalence. So this is what we mean to fit a model. So basically translating the raw data of economic closures into an observed epidemic trajectory. So this basically is one of the big advantages of our model. It makes all of everything that we're doing much more realistic. I guess another point just how we could validate the projections of our model. One thing to bear in mind is that often policymakers won't do exactly the scenarios that we're considering. They might do something and then change their mind after 2 weeks or after a month. And so it's very difficult to have data on the exact scenario in which we were projecting.
Thanks. What about one question that I had was whether you can, or how you account for maybe sectors having variation in their ability to switch to remote or at-home work, right? There's obviously, there might be a bias on the part of, the type of job that I have, but I think my productivity doesn't go to zero when I work from home. It probably goes down some, but not necessarily completely. But I imagine with other jobs, that's not possible. So do you consider that at all?
You want to answer, Patrick?
Sure, yes. So every sector we consider has a corresponding work from home rate, which we have estimated from data in the UK. So sectors such as finance and IT will have quite high working from home proportions, whereas other sectors, say manufacturing, for example, will have much lower working from home proportions, reflecting their inability to carry out work remotely. And so these are accounted for when we are doing optimizations or different scenarios, and basically they will modify the underlying contact rates. And so a sector in which there is a large proportion able to work from home will be favored for reopening over a sector in which there is a lower ability to work from home and which may also have much higher contact rates.
Maybe we're at time, maybe we can squeeze in one more. We have one more question in the chat that popped in. Vagish asks about how you estimated transmission rates for each sector to translate sector closures into impact on cases and deaths. So I guess.
Yeah, so we have a slightly shoddy French survey where we use occupation to translate into sectors. Unfortunately, there's not better information available, and we are really lobbying to get better data contact rates by economic sector and by occupation. We have relatively good information by age group, right? So there have been epidemiological studies being done for years and years on that, but not by economic sector, surprisingly. There is also actually another question by Reg in the chat. What about the informal sector, which I think is a really important question, because many low and middle income countries where we work in, of course, the informal sector is very important. Well, for two reasons. First, it's very difficult to determine what is the GVA contribution of the informal economy. Although attempts are being made in the national accounts to do that, to value the informal sector, informal economy in each sector. But then also it's important to note that the sector cannot really effectively be closed down. It's very difficult to close it down. I mean, if you can't raise tax from it, then it's even more difficult, I think, to close down production in this sector completely. So I think that limits really the mitigation opportunities for lower middle income countries with a high informality in their economy. So it's a good question. Thank you.
Question. Well, I think we've reached our time, and I wanted to thank both of you for excellent talk. We had, I think at our peak, about 65 participants and lots of questions and discussions. So I think that was great success. And so thanks again. And thanks everyone for attending this seminar series.
Well, thank you so much for inviting us to attend, Steve.
All right. All right.
Bye, everyone. And please get in touch if you have any questions.
All right.
Bye.
Bye-bye.